Hello everyone, welcome back to this series of lectures in gastroenterology. In the last class, we had learned about our approach to malabsorption. In today's class, we'll be learning about the various disorders of malabsorption. So, let us start off with the first and the most important one. This is your celiac disease. So, celiac disease is also called as gluten-sensitive enteropathy or celiac Sprue. So, what is the basic problem here? So, this is a malabsorptive syndrome where there are antibodies to tissue transglutaminase. What is TTG? It is tissue transglutaminase. Okay. And what is the antigen that is responsible for this? This is the antigen called gliadin. Okay. Antigen that is responsible for this is an antigen called gliadin. So, what happens here is that there is this substance called gluten which is present in a lot of food products. So, what are the food products which have this substance gluten? This is your wheat, rye, barley and oats. Okay. So, they have this substance called gluten, and in this gluten there is an antigen which is called as your gliadin. So, in certain people, in certain predisposed individuals, due to unknown reasons, there are antibodies which are produced against this antigen which is gliadin. Or in other words, this is an autoimmune disorder where our immunity is working against certain antigens like this gliadin antigen. Okay. And these antibodies which are produced then act against the intestinal mucosa as well. So, whenever you have exposure to gluten, exposure to gliadin, it is stimulated and you get this disease which is called as your celiac disease. Right, so they have a lot of gluten sensitivity, they have a gluten hyperresponsiveness, and the enteropathy that occurs as a result of it is called as a gluten sensitive enteropathy or your celiac disease. So, the areas involved most commonly the area that is involved is your proximal small intestine, Okay, genetic factors HLA, DQ2 and DQ8 are some of the HLAs which are associated with celiac disease. Okay, so what is celiac disease in essential? So, this is basically enteropathy that occurs due to antibodies or immunity, autoimmunity against this gluten which is there in your various food products. So, every time they have these food products, patients who are gluten sensitive can develop this enteropathy which is called as celiac disease. Fine. Now, let us look at the clinical features. So, the most common clinical feature is that there is diarrhea. Okay. So, what are the mechanisms for diarrhea? Most importantly, there can be a secretory diarrhea, mainly because excess amount of this gluten causes epithelial endothelial activation. So, all of the intestinal lining is activated and there is excessive secretion. So, there can be a secretory diarrhea in your celiac disease. Then, weight loss because of chronic malabsorption. Weight loss because of chronic malabsorption. The small intestine is the most affected. There is chronic malabsorption and there can be weight loss. Okay. So, weight loss and diarrhea are the two most important features for celiac disease. So, most of the time celiacs basically present as a chronic long-standing diarrhea with malabsorption. And the cause is most often unknown, and later on we find out that they probably are gluten sensitive. And what is atypical celiac disease? Atypical celiac disease is when the disease presents without diarrhea and it predominantly presents with iron deficiency anemia, LFT changes. Why iron deficiency anemia? Because iron is predominantly absorbed in the small intestine. Then there can be ataxia where there is neuropathy. Then there can be osteoporosis or failure to thrive. So, if all these symptoms are present, then this is what we call as the atypical celiac disease. Okay. And what are the associated diseases? Celiac disease is predominantly an autoimmune disease. So, it's associated with lot of other autoimmune conditions like type 1 diabetes, vitiligo, autoimmune hypothyroidism like your Hashimoto's. Right. So, these are all the associations. So, what are the associated disease? Associated diseases are type 1 DM, vitiligo, hypothyroidism. Sometimes other autoimmune disorders like SLE can also be associated. Now, celiacs can have a specific type of rash, where around the umbilicus you can get these kind of vesicular eruptions. And this is what we call as your dermatitis hypertiformis, which is characterized by IgA deposits. Okay, so this is your dermatitis herpetiformis. Now let us look how do we diagnose celiac disease. So there are a specific group of antibodies which are used to diagnose celiac disease. Remember that celiac, though we have understood in our approach to malabsorption that celiac disease has certain characteristic biopsy findings, but it is not very specific for celiac disease. That is the reason why you require antibodies along with your biopsy findings to confirm the diagnosis of celiac. Right? So the most specific or highly specific antibodies are your anti-endomysial antibodies. Then you have another group of antibodies which are called as the anti-tissue transglutaminase, IgA subtype. So IgA anti-TTG, this is also called as anti-TTG. This is both sensitive and specific. But in patients where there is IgA deficiency, then you cannot measure this IgA anti-TTG, that will be negative. So in such patients you do a IgG anti-TTG. So this is both sensitive and specific. Most specific is your anti-endomysial antibody. Apart from this, you have anti-gliadin antibodies as well, but these are not very sensitive. Okay. Then we can do a biopsy, and these are your biopsy findings. So what do you find here? This is how your normal intestine looks. This is your normal intestine. Here what can you see? The villus is atrophy. There is villus atrophy. Right? So there is villus atrophy. Okay. The villi are blunted and the crypts are hypertrophied. Right? So you can see that the villus is blunted and the crypts are hypertrophied, and you have a lot of inflammatory exudates all over. There's a lot of inflammation that is going on in your celiac disease. Okay. So this is about the various biopsy features of celiac. Fine. So this is about how you diagnose it. Now let us understand what is refractory celiac disease. So refractory celiac disease is basically persistent changes on histopathological examination, and the patient continues to be symptomatic despite 1 year of a strict gluten-free diet. You have removed the gluten, you have removed the antigen from the diet, but in spite of that he is having continued histopathological changes and he continues to be symptomatic. Then this is refractory celiac disease. And why is refractory celiac disease important? Because this can result in an increased risk of lymphomas. There is an increased risk of lymphomas, your GI lymphomas. Okay. So what is the treatment? The only proven treatment for celiac disease is basically a gluten-free diet. Okay. So we see a lot of fads around in the internet or in your television. So everyone wants to have a gluten-free diet. So is it useful for everyone? No. So gluten-free diet is a strict therapeutic measure which is useful only for patients with celiac disease. So if a normal individual follows a gluten-free diet, that is not going to improve his digestive habits at all. So we'll have to avoid these fads, and very importantly, gluten-free diet is the most important first-line therapy for celiac disease. Then corticosteroids can be given in refractory celiac disease. So in refractory celiac disease, corticosteroids or your anti-CD20 rituximab trial can be tried, but it is not very definitive. Okay. So this is about your first malabsorptive disorder, which is your celiac disease. Now let us look at the next disorder, which is the tropical sprue. So tropical sprue, as the name suggests, is very common in your tropical regions. That's the reason why it's called so. So this is most often post-infectious in nature. Right? It's post-infectious in nature and it presents very similar to celiac disease, chronic diarrhea, malabsorption. Okay. And how do you diagnose this tropical sprue? Tropical sprue is diagnosed when the stool cysts and trophocytes are negative. So you rule out active infection. There is no active infection, especially in tropical countries. Chronic diarrhea can be due to infective processes like Giardia and so on. Right? So you do a stool for cyst and trophozoite, rule out active infection, and then you can consider the diagnosis of tropical sprue. Okay, right? So this is one condition which basically involves both the proximal and the distal small intestine. So iron is absorbed from proximal small intestine, B12 is absorbed from the distal small intestine. So this can have both iron and B12 and folate deficiency. So this can have both iron plus B12 plus folate deficiency. Okay. So which organisms have been implicated in the development of this? So in tropical areas, organisms such as Klebsiella, Enterobacter cloacae, these organisms which have infected the individual caused diarrhea for some time, and post-infectious process, it can result in a tropical sprue. So histopathologically, it is the same, almost same as your celiac disease. This is almost same or similar to your celiac disease. So histopathologically, you cannot differentiate between celiac sprue and tropical sprue. So in tropical sprue, the celiac disease antibodies are usually negative. So any disease which presents similar to celiac disease, having a histopathology similar to celiac disease, always have a high suspicion in the tropical areas for tropical sprue. Now since this is a post-infectious process, the treatment is usually with antibiotics like tetracycline along with folic acid, because folic acid deficiency can be there for 6 months. Right, so this is a 6 months treatment of antibiotics plus folic acid. Antibiotic used is tetracycline. Okay, so this is about your tropical sprue. Now let us look at the next malabsorptive disorder, which is your Whipples disease. So Whipples disease is basically a disorder which is an infection caused by the organism Trophirema Whippli. So this is caused by the organism Trophirema Whippli. Okay, so this is a gram-positive organism which basically affects the GI tract, but it is a multi-system disorder. It can affect the GI tract, it can affect the kidneys, it can affect the nervous system as well, and it can affect the joints as well. So why we are studying it here? Because we are going to understand the GI manifestations of Whipples disease. So Whipples disease is caused by the organism Trophirema Whippli, which is a gram-positive organism. So what are the clinical features of Whipples disease? So there are a lot of phenotypes of Whipples disease. So GIT involvement basically causes malabsorption. GIT involvement predominantly causes malabsorption. And when you do a biopsy, you basically find that there are PAS positive. What is the stain used? It is per-iodic acid skip. So PAS positive macrophages in the lamina propria is your diagnostic clincher on the biopsy for Whipples disease. PAS positive macrophages. Okay, fine. Joint. In the joint, what does it cause? It causes a form of a migratory small joint migratory polyarthritis. Okay, it causes a small joint. It predominantly involves a small joint, and it's a migratory polyarthritis, which means what? If one joint is swollen, then it comes down, then it moves to another joint, then that improves, then another joint is involved, and so on. Okay, in the heart, what does it cause? In the heart, it can cause a infective endocarditis. Whipples disease can cause infective endocarditis, it can cause myocarditis as well. Then, what are the CNS manifestations of Whipples disease? So, CNS manifestations of Whipples disease includes ataxia. Then you can have certain characteristic features like oculomasticatory, myarrhythmia. So this is basically a movement disorder where there is simultaneous movement of the eyes and the mouth, oculomasticatory myarrhythmia. Apart from that, you can also have some forms of opsoclonus, myoclonus. What is the meaning of opsoclonus, myoclonus? Basically, there are clonic movements of the eyes as well as the feet. Okay, so opsoclonus, myoclonus syndrome. How do you diagnose this? So you diagnose it basically on the biopsy. Apart from that, there are certain PCR techniques which are used for diagnosis of the organism, but you should have a high index of suspicion for the diagnosis of Whipples disease. So the treatment is basically using your third gen cephalosporin like ceftriaxone or beta-lactam antibiotics like meropenem for 14 days. And after 14 days of induction therapy, you will have to give them a cotrimoxazole for long term, maybe like a 6-month treatment for complete eradication of the bacteria. Okay. So this is about your Whipples disease. Now let us look at the next malabsorptive syndrome, which is your SIBO. SIBO stands for small intestinal bacterial overgrowth. So as the name suggests, there is excessive bacteria in the small intestine, and these excessive bacteria can result in abdominal pain, bloating and malabsorption, chronic diarrhea. So what are the causes? So conditions where there is decreased motility. So conditions where there is decreased intestinal motility, as in scleroderma, diabetes, post-surgical patients, Crohn's disease. All of these can cause stagnation of the food and bacterial overgrowth resulting in SIBO. Okay. So what happens when there is bacterial overgrowth? When there is bacterial overgrowth, there is deconjugation of the bile. This deconjugation of the bile, what happens is that this excess bile gets reabsorbed. So we know that the conjugated bilirubin is the one which is soluble in your bile and intestinal secretions. So once it gets deconjugated, the bile gets reabsorbed. So in essential, it results in a luminal bile acid deficiency. Though there is no actual bile acid deficiency, because of this deconjugation and reabsorption, there is a luminal bile acid deficiency which results in your malabsorption. Okay, so this is the basic pathophysiology behind your malabsorption of SIBO. So what are the clinical features? There is B12 deficiency, but there is no folic acid deficiency. The B12 levels are low, but the folate levels are normal. Why? Because folic acid is produced by these bacteria. It is produced by the bacteria. Okay. The gold standard diagnosis is when you take a small intestinal aspirate and the bacterial count is more than 10 power 5 colony forming units per microliter of the aspirate, right? So when you take a small intestinal aspirate and the colony count is more than 10 power 5, then this is the gold standard diagnosis for small intestinal bacterial overgrowth. Apart from that, you can do a hydrogen breath test, right? But the hydrogen breath test can also be positive in lactose intolerant patient or lactase deficiency. The other condition where the hydrogen breath test is positive is your SIBO. How do you treat this condition? You treat it with antibiotics like rifaximin, which is given 400 mg BD, and this can be given for a period of 7 to 14 days. Okay, so this is about your small intestinal bacterial overgrowth. So with this, we've come to the end of our discussion on malabsorption. So in the first part, we had learnt about the approach. In the second portion, we have learnt about some of the most important malabsorptive syndromes. Thank you.